Okay, anti-epileptic drugs. So anti-epileptic drugs are drugs that are used for seizures, right? Used for managing seizure disorders. They might also be called anticonvulsants or anti-seizure drugs, anti-epileptics. So let's start by differentiating between a convulsion and a seizure. A convulsion is a behavior with sudden involuntary contraction of the muscles. Oftentimes, our client also loses consciousness. A seizure is an event characterized by changes in the brain's electrical activity. So a seizure happens in the brain, a convulsion happens in the muscles. Does that make sense? Convulsions can occur during seizures, but not all seizures are characterized by convulsions. We have many different drugs that we use to treat seizures. 6 specific categories: hydantoins, carboxylic acid derivatives, succinamines, oxazolidinediones. I cannot say that word for the life of me, and I've tried to pronounce it like 4 different times before this video, and I'm struggling. Benzodiazepines, which we've learned about before, and a group of non-specified seizure drugs that we're going to talk about. So let's start with that first category, hydantoins. Hydantoins stabilize the hyperexcitability postsynaptically in the motor cortex of the brain. So they stabilize hyperexcitability. So increased nervous system is stabilized using a hydantoin. Examples of hydantoins: ethitoin, fosphenytoin, and phenytoin. What makes hydantoins special is they are a great long-term solution for status epilepticus, okay? So we might give a benzo like diazepam to get someone out of status epilepticus acutely. And then if we want to prevent them from going back into a seizure that's lasting a long time, which is, characteristic of status epilepticus, you would want to go ahead and give them a longer acting medication like phenytoin or fosphenytoin. Hydantoins also treat tonic-clonic seizures, and they are given to prophylactically prevent seizures. Adverse effects of hydantoins: ataxia, central nervous system depression, headache, low blood pressure, nystagmus, which is where the eyes are darting back and forth and they're unable to focus, mental confusion, slurred speech, dizziness, drowsiness, nausea and vomiting, gingival hyperplasia, and rash. Adverse effects of hydantoins. Contraindications: who should not get a hydantoin? Well, if your client has sinus bradycardia, a sinoatrial block, heart block, right? Adams-Stokes syndrome, a second or third degree heart block, pregnancy, lactation, or they have hepatic abnormalities, they should not be put on a hydantoin like phenytoin. We're going to be careful with people who have low blood pressure, already have some type of heart issue causing a myocardial insufficiency, their heart's not doing enough work, right? Or they have some type of hepatic impairment. Phenytoins, great for status epilepticus, getting your client out of those prolonged seizures after you've given an acute med. Okay, examples include ethitoin, fosphenytoin, and phenytoin. Next category, carboxylic acid derivatives. Big one here, Depakote, valproic acid, Depakote. These actually increase GABA, right? GABA, and GABA is that really, really long substance that we find in the brain, right? That helps to stabilize the cell membrane. I'm just going to go up to see if we can look up that word because it is ridiculously long and I never can remember it when I'm trying to. GABA. So when we increase GABA in the brain, we're able to stabilize the cell membranes, and therefore we're not producing those errant signals that are hyperstimulating our central nervous system and causing a seizure or convulsion. So the GABA neurotransmitter, I'm looking up the actual name here because it's really long. Gamma aminobutyric acid. Gamma aminobutyric acid, GABA, right? It works in the central nervous system as an inhibitory neurotransmitter. So it keeps the signals from being sent. And if we have errant signals being sent out by the brain, seizure, right? We need to increase that inhibitory neurotransmitter, increase the GABA. with a medication like Depakote or valproic acid. We use these for clients. We use Depakote for clients who have epilepsy, migraine headaches, or mania. Adverse effects of valproic acid: headache, somnolence, dizziness, tremor, nausea, vomiting, or diplopia, double vision. Contraindications: who should not have it? Someone who has kidney issues or someone who's pregnant. We want to be careful in people that have liver disease or a neuro disorder. We just a fun fact: valproic acid has been associated with an increased risk of pancreatitis development. So be aware of that. If your client has like chronic pancreatitis, they probably should not be on valproic acid. The next class of medications are called succinamides. The two big ones are ethosuximide and methosuximide. These decrease the motor cortex, which creates a higher stimulus for threshold. So by decreasing the motor cortex, it requires a lot more signal to stimulate the motor action, right? So you're not going to be as sensitive to having seizure. Focal seizures, which are specific to one area of the brain, that's what we're going to use succinamides for, focal seizures. Adverse effects include drowsiness, ataxia, dizziness, nausea, vomiting, urinary frequency, pruritus, urticaria, gingival hyperplasia, and succinamides can cause issues with our ability to produce new cells, and therefore we don't want to give this to anyone who has bone marrow suppression already, right? Bone marrow suppression. If they have hepatic or renal issues, or if they have lupus, we do not want them to be on a succinamide as well. Okay, so we've talked about hydantoins like phenytoin, carboxylic acid derivatives, which is like valproic acid, Depakote, and succinamides. Let's talk about this class that I have a hard time pronouncing: oxazolidinidiones. Oxazolidinidiones. Okay, I'm gonna try my best. Example. So the one I want you to know is trimethadione. And the action that it has in the body is it decreases repetitive synaptic transmission of nerve impulses. So it decreases those repeated transmissions, those repeated signals. We use these with epilepsy. Adverse effects can include dizziness, drowsiness, nausea, vomiting, maybe some photosensitivity, personality changes, increased irritability, headache, and fatigue. Don't want to give these to anybody who's allergic, but also we don't want to give trimethadione to anyone who's pregnant, because it is associated with fetal malformation, so deformities. It's a teratogen. Trimethadione should only be given when we've tried other drugs for seizure and they have not worked, because the adverse reactions here are very serious as far as their severity, right? They're pretty debilitating. We don't want to use these in clients who have eye disorders unless it's risk versus benefit, and they've decided that it's important for this client to have the medication because it is associated with retinal or optic nerve issues, right? It really changes their vision. So big like assessment thing for the nurse would be making sure that your client is following up with their ophthalmologist and that they are having their vision checked for any worsening visual acuity. Benzodiazepines. This is a really short section because we've already talked about benzos. The ones that we use for seizures are clonazepam, which is Klonopin, diazepam, which is Valium, and then lorazepam, which is Ativan. We know that they can be used for all different kinds of things. On this slide, we're just going to be talking about the way that they work for seizures. So they treat seizure disorders, focal seizures, and status epilepticus acutely. Acutely. I want you guys to note that. You give the benzo first, you give the diazepam first, and then you follow it up with a longer acting anti-epileptic like phenytoin. Uses, we talked about, let's talk about adverse effects. Drowsiness, depression. Your client might just be really down because these are CNS depressants, right? Ataxia, anorexia, diarrhea, constipation, dry mouth, palpitations, rash, lethargy, somnolence, or fatigue. Okay. Non-specified drugs. And ironically, this weird class of drugs thrown on the end that don't actually fall into another class really is our biggest chunk of anti-epileptic drugs. So we've talked about the phenytoins, we talked about the medications that I can't pronounce, the oxalididiones, right? Succinamides, we talked about carboxylic acid derivatives. Now we've got all of these other epilepsy drugs. Acetazolamide, carbamazepine, which is Tegretol, gabapentin, Neurontin, lacosamide, which is Vimpat, lamotrigine, which is Lamictal. Here's a big one: levetiracetam, which is Keppra, magnesium, pregabalin or Lyrica, and topiramate, also known as Topamax. These are very, very common anti-epileptic drugs. Okay, used for epilepsy, focal seizures, tonic-clonic seizures, eclamptic seizures, specifically MAG with that one, right? Neuropathic pain as well, and also migraine. Adverse effects. So these are very specific to the drug, right? Because this isn't truly a class, it's just a unclassified class. Lamictal, we want to be watching when we give Lamictal. What are we watching? So it's lamotrigine. We want to be looking for Stevens-Johnson syndrome. So we're assessing the skin. We're going to report any rash. We're going to be looking for lesions in the mouth, right? Any blistering, peeling of the skin. It needs to be reported to the doctor immediately. When we give carbamazepine or trimethadione, we want to watch for pancytopenia, leukopenia, aplastic anemia. Symptoms of decreased blood counts can include easy bruising or bleeding, increased risk for infection, right? Drowsiness, dizziness, nausea, diarrhea, constipation, visual disturbances, vomiting, somnolence, double vision, risk of infection, and fatigue. Go with those. Okay, go with carbamazepine and trimethadione. But also with pretty much all of these drugs, they're going to be at increased risk for drowsiness and dizziness, right? Potentially some nausea, changes in their GI. And then magnesium can cause central nervous system depression. Well, that's what we're giving it for, right? Because we're having a seizure, particularly an eclamptic seizure, which means during pregnancy related to a condition known as eclampsia, right? So we want to decrease the central nervous system so they're not convulsing. So the client is going to have decreased deep tendon reflexes, etc. Contraindications. We don't want to give carbamazepine to any client that's on an MAOI or patients that have bone marrow depression, renal or hepatic issues, or are pregnant. Precautions. We want to be careful giving any type of seizure medication to a client with glaucoma or because of their increased intraocular pressure, or a client who has a history of cardiac, renal, hepatic issues, or psychiatric disorders. Okay, let's go through the nursing process. Assessment. We want to get a thorough patient history. We want the family to tell us about the seizures, right? We want the family to give us a really good description of what's been going on, specifically type of activity, the movements, how often the seizures are, how long the seizures are, if the client knows that the seizure is coming on, and if so, what is that aura experience like for them? Do they lose consciousness or not? Do they have triggers or precipitating factors that make them seize? We need to document not just the family and patient's responses to those questions, but also if we observe seizures, what we see. We need to document what we saw before the seizure, what we saw during the seizure, and what we saw after the seizure. We need to be checking serum levels of a lot of these drugs. They require regular checks, like phenytoin is one of them. We want to be reviewing labs and imaging, especially kidney and liver labs, to make sure that we don't have any issues going into this, right? Carbamazepine, we want to be checking their white blood cell count before we give it because of increased risk of infection and suppression, right? Leukopenia. Some medications like carbazepine, we want to be checking their sodium levels, also oxcarbazepine. Felbamate, we want to be checking liver function. Phenytoin, we need to be constantly monitoring their amount of phenytoin in their blood. And then valproic acid, we want to be watching their platelet counts and their serum ammonia levels. Okay, diagnosis. The RN might diagnose your client with risk for injury, risk for impaired skin integrity, risk for infection, or impaired oral mucous membranes, really specifically due to gingival hyperplasia of people taking like phenytoin. What do we want to see? We want to see our client respond to the drug the way we want them to. We want to mitigate or manage any adverse reactions. We want our client to understand and comply with treatment. Interventions. Do not miss or omit a dose of antiepileptic medication. If your client is going to stop taking their seizure med, They have to gradually taper and withdraw. They cannot just abruptly stop. It's going to cause major issues. Teach your client that there is a genetically linked inability to metabolize phenytoin, and that's why we have to be drawing those drug levels. When making sure we're not getting into those toxic levels. Level above 20 micrograms per milliliter is going to indicate toxicity. And at that point, we might start to see slurred speech, ataxia, lethargy, dizziness, nausea, or vomiting. Okay. And then we know that phenytoin can cause some GI issues anyway. So we want to give it orally with meals, or if we're giving it orally, we want to give it with meals to decrease those signs and symptoms of GI upset. And then obviously IV is preferred when we're doing parenteral. IM is going to be a slower absorption rate, right? And then also phenytoin can not absorb correctly, or it can have erratic absorption. Injecting phenytoin can be ouchy. It can be painful. There can be muscle damage. So if we can do IV, if we need to give it parenterally, we want to do that. Benzodiazepines. Benzodiazepines, we've talked about this. I've really emphasized this point, are great for short action, acute seizure activity. But because that seizure activity may come back or continue to worsen, we want to follow it up with a longer acting antiepileptic med like phenytoin. Okay, diazepam. Diazepam is Valium. If it's given IV, you might see drug precipitation. That's where you got solid chunks in your liquid of the drug. Well, that's not good, because if we push that into the body, we've now created emboli, right? So no, thank you. Just be aware of that and be careful when you're giving it IV that you're not having precipitate forming. You want to push benzodiazepines very slowly if you're doing IV push, and obviously you guys won't because you're going to be LPNs, but just so you know, benzodiazepine should be pushed pretty slowly, a minute for every 5 milligrams. Clients on any anti-seizure medication may need help with ambulation or their activities of daily living. So because of their dizziness or fatigue, etc., or even just the debilitation of the disease process itself. Teach your client to rise slowly and dangle at the bedside to prevent falls and injury. Teach your clients about adverse effects like drowsiness, but also explain to them that all of those adverse effects typically decrease as you continue to use the drugs. Test their swallowing ability before you give them any kind of oral antiepileptic. If they're not able to swallow, then they should not have the drug, right, orally. So you might give them a small cup of water, have them take a couple small sips and see how they do. If they have difficulty with the water, don't give them the medicine. And then tell the doctor as soon as possible what's going on. You want to use fall precautions to prevent injury in these clients, and you want to encourage them to continue to see an eye doctor like we talked about due to potential vision changes while on antiepileptics. If your client has photophobia, you can dim the lights. If they have photosensitivity, however, that's related to their skin sensitivity to sunlight and potential for rash, right? So try to stay out of the sun, have some sunscreen, protective clothing, etc. If they do develop a rash, there is a way that we want to handle this. Because of the risk of Stevens-Johnson syndrome, if there's an exfoliative, purpuric, or bullous rash, stop taking the med. Report to the doctor immediately, right? If they develop a mild sunburn type rash, stop taking the med, alert the doctor, but most of the time we're going to be okay to continue giving that medication. So after that rash goes away, we can resume the med. We just don't want the client scratching at it or using soap that might irritate it. Okay, we want to watch for signs and symptoms of pancytopenia with some of these anti-epileptic medications. So signs and symptoms of pancytopenia. Obviously, we could do lab draws and see in our counts that we have low cell counts. But your client may also experience sore throat, fever, malaise, bleeding of the mucous membranes, nosebleeds, epistaxis, right? Or easy bruising. When they're on succinimides, we need to be checking their CBCs and getting their differential counts. There is the potential for bone marrow depression. It can get really serious. So we want to be watching their blood counts. If your client becomes pancytopenic, we need to take pancytopenia precautions. So if they don't have enough platelets to clot, if they don't have enough red blood cells to carry oxygen, etc., we don't want them bleeding. We know they're going to be at increased risk for bleeding. So have your client use a soft bristle toothbrush and nothing like crazy inside the mouth, and they'll have bleeding gums, right? We also want them to be careful with their extremities. Be watching like where they put their arms, where they put their legs, etc. Not just banging them into everything and potentially bruising and bleeding there. Report any new hematologic changes immediately to the doctor. And if your client is on those Heidentoens for a long time, we heard that they can cause the gingival hyperplasia or gingivitis, overgrowth of the gums, or potentially inflammation, infection of the gums. After every meal, provide oral care to your client, especially if they're on that Heidentoen, right? And then report any gum changes to the doctor. Teaching the clients about how to handle the seizures and their family about how to handle the seizures is going to be probably your biggest teaching point for a client that's struggling with these type of neuro issues. So the client needs to know what to do before, during, and after the seizure. Additionally, the client should know not to drive, maybe even care for children or go to work, depending on what they do at work, while their seizures are we're still working out some type of control or medication for their seizures. We want to make sure they're well controlled before they resume those type of activities. We also want to monitor for any of the other adverse reactions and try to manage those as best as possible. Teach the family never to put anything in the patient's mouth during a seizure. That's no good, right? And then no alcohol while on anti-epileptic meds. And then lastly, a medic alert bracelet. Really important for your client to wear one of those because it's going to tell the EMS if they arrive on the scene that this isn't an epileptic patient, and they'll know how to handle the client better than if they just show up and the client's unconscious or convulsing and they might think it's something else, right? Evaluation. How do we know we've been successful? Well, if we've accomplished whatever we tried to accomplish and we controlled our convulsions, that's good. That's a positive outcome, right? If the client didn't get injured, they didn't fall, they didn't hurt themselves during surgery or seizure, that's great. If we identified, reported, mitigated, managed any adverse reactions, that's awesome. Patient verbalizes the importance of compliance if they understand and comply, right? Understand and comply, not just the patient too, but the family members. Okay, here's our questions. Convulsion and seizure are terms often used interchangeably to describe sudden involuntary muscle contractions due to changes in brain electrical activity. This is true, but technically seizures are the electrical disruption and convulsion is the muscular contraction. Seizures can be caused by disease, injury, or metabolic changes. They also can be just inherited, congenital. Anticonvulsive drugs are used to depress abnormal nerve impulses discharged in the brain. True. We want to decrease those abnormal impulses so that our client does not have a convulsion. When discontinued, we always have to taper these down or we have like a rebound seizure activity. Okay, that's anti-epileptic drugs. I will see you in chapter 30.